Good evening. Welcome to the EUROGEN webinar programme. I'm Michel Wyndaele and I'm the manager of one of the European reference networks that we call EUROGEN. There were 24 European reference networks created and funded by the European Commission since 2017, and they all aim to improve care for patients with rare diseases and complex conditions that need highly specialised treatment. And the reference network EUROGEN deals with rare urorectogenital diseases and complex conditions. So they're all diseases or conditions that need highly specialised surgery, so where the expertise is rare. And we're currently a network of 56 healthcare providers across 20 member states. So some of our activities, well, I hope you noticed from the slides at the beginning that we use a special tool called the Clinical Patient Management System, CPMS, to conduct cross-border virtual MDT discussions. Now, this service is free to any healthcare professional working in any of the European Union member states, and we'd be delighted to offer the advice of the experts in our network if you have a particularly complex or tricky case. Please do get in touch with us via our website. We also conduct training and education activities together, like this one. We also write clinical guidelines together as a network, which of course improves care for patients. And another very exciting activity is we're now rolling out the EUROGEN patient registry. About half of our healthcare providers are already entering patient data. So this is very exciting. We hope that this will provide long-term clinical outcomes for patients with these rare and tricky diseases. And as you all know, one of the problems with patients with rare diseases is that we have fragmented and scattered data. So we really hope that this will improve care for patients going forward. So without further ado, this evening's webinar is on primary amyloidosis of the lower urinary tract, and we're really delighted to have 3 speakers from the University Medical Center of Utrecht in the Netherlands. This webinar is accredited with CME points, so please complete the survey at the end of the webinar. And one of the great things is now collaboration across different ERNs, and we're delighted to have an expert from EuroBloodNet here with us this evening. So tonight's speakers are Professor Monique Minnema, and she's a haematology expert, so coming from the ERN Rare EuroBloodNet. And we also have Dr. Sanne Jansen, and she's a urologist, and also Dr. Michel Wyndaele, and he's a urologist. So thank you so much to our 3 expert speakers this evening, and I hope you enjoy the webinar.
And then we'll start. We are doing a primary webinar on primary amyloidosis of the lower urinary tract. I'm Michel Wyndaele, and next to me is Sanne Jansen. And then we have also Professor Minnema, who will talk during the webinar. So, yes. To start, we have our disclaimers. For all 3 of us, these are paid to the institution. And then the outline. So first we want to clarify why we think this is a very valuable topic for a rare disease network and a reference network, both for urologists and hematologists. We will illustrate some cases of urethral amyloidosis and bladder amyloidosis, and then we'll go through the urological literature and see where it starts and ends, and actually that is a nice bridge to the new insights that we will need to take into account, which will be provided by Professor Minnema, and then we'll have the take-home messages. So I'll start with a case of a 39-year-old male who was referred to me for a distal urethral stricture. He went to a colleague urologist with lower urinary tract symptoms, consisting of both storage symptoms, urgency, frequency, and voiding symptoms, hesitancy, weak stream, spray, and he had pain in the lower abdomen during micturition. Also, there were symptoms during erection and ejaculation of pain, quite a high IPSS and severe impact on his quality of life. Physical examination of the penis and the penile urethra showed a very painful and solid aspect of the urethra. So externally, cystoscopy and biopsies were done. The biopsies were done because the urethra had a very irregular aspect, and they found amyloid deposits in the penobulbar urethra. After the cystoscopy, they performed an ultrasound, and as you can see in the left image, that's an image of the spongiosum in longitudinal, where in the middle there is the urethral lumen, but you can see a very irregular surface. An MRI was performed as well, showing a very similar image of a deposit in the spongiosum with an irregular form or structure of the urethra itself. This is what the cystoscopy showed. Always difficult to get clear images, but you can see sort of a yellowish deposit and an easily bleeding area right next to it. So the plan was to treat it as a urethral stricture. So we planned a distal urethroplasty. I consented him for both a single and a two-stage procedure based on the perioperative findings. And eventually, during the operation, we did a dorsal inlay, so a classic ASOPA, in a single stage, quite long, 11 centimeters of buccal mucosa were used, so 2 cheeks. We did a biopsy of the urethral plate and the frozen section during the procedure because we wanted to make very sure that this was no malignancy, and that came back as negative. And the spongiosum was completely filled with deposits and very stiff. So we did quite an extensive resection, not a full resection, and that allowed us to do a single stage. The pathology report came back 2 weeks later and showed AL amyloidosis and lambda monotypical plasma cell proliferation. So we referred him to the hematologist with the question, is this a local disease or a systemic disease? They said their evaluation showed no systemic disease, but they saw an indication for treatment with chemotherapy for 3 weeks, which to me came as a surprise, but we'll get into that later on. To continue the case, he had a recurrence of his stricture, which is also quite typical in urethral amyloidosis. So we planned a reconstruction in 2 stages after the chemotherapy. During the first stage, we did again biopsies, also of the bladder, because he had a small spot in the bladder, which we wanted to make sure was no amyloidosis or anything else, which was the case. And in the urethra, there was still extensive amyloid deposits, not surprising, but the monotypical cells could no longer be found. And the second stage for this patient is to follow. So in the urological literature, there's about 8 case reports or series and 1 nice review already dating back from 2011 with about 50 patients reported. The diagnosis is based on symptoms, and the symptoms are very similar to urethral stricture disease. So that's how you eventually get to the diagnosis. And the appearance may mimic urethral cancer. So that's why you do biopsies or why you think of doing biopsies. It's also advised to do an MRI to have an idea of the extent of disease before you do surgery. In terms of treatment, in essence, it is a benign course of a disease, not a benign disease, but a benign course of the disease. So you can do internal urethrotomy or dilatation with large risk of recurrence. There is a report on urethral injections of DMSO, which was in an elderly patient not fit for surgery, which was published. Or you can do a urethroplasty with the recommendation to resect as much affected tissue as possible and then reconstruct according to the principles. Follow-up should be long-term, as there is a chance of recurrence. There's actually a nice little section on this in the EUROGEN book of rare and complex urology. So for those of you who are interested in this and many other very interesting topics, the book is available and the link is shown.
Yes, then we had another interesting case to share. It's a female patient of 60 years old who was seen in another hospital, a hysterectomy and ovarian cyst in her medical history, had macroscopic hematuria and urgency, and a cystoscopy showed a lesion. The cytology came back with no suspicious cells for malignancy. They did a TUR of the bladder and they thought it was not complete. It was also in the area of the right ostium. She had hydronephrosis. Renography showed still a good function of the right kidney, and the pathology showed no malignancy or inflammation. And she was referred to us, and they said, "What could this be?" And here you see the imaging. You cannot, in this picture, really see the hydronephrosis except for this small dilated segment of the ureter on the right side. And here, as you can see, it was like a segment, not semicircular, but it was a pretty extensive lesion around the right ostium. Also here on MRI, it showed here's a thin bladder wall, and here at the place of the lesion after TUR, it was not, it was still very thickened. And what the thing we did was ask a second opinion of the pathology sample, and needs to be said, I did not ask specifically for a Congo red stain. So I just said they excluded malignancy, but we don't really have a lead what it could be, and there's a very obvious location. So I'm glad our pathology department was very forward, and they did the colorings that they needed to do, and they came back with a certain diagnosis of AL amyloidosis and kappa monotypical plasma cells. Here you see the cystoscopy. So this was after the TUR, difficult images, but here you also see these yellow deposits of proteins, which are submucosal lesions, and you see edema, and it also bleeds very easily, explaining the hematuria. We also referred her to our colleagues from the hematology department. Also, fortunately, no signs of a systemic amyloidosis. And she received no chemotherapy, but local radiotherapy, 12 times 2 gray, so it's relatively low doses. The radiotherapist told us we could not really expect the lesion to go away, but it would have the effect of stabilizing the proliferation of proteins and therefore stabilizing also the disease. We thought long whether we should do a surgical intervention, but the hydronephrosis was already present for quite a long time with good kidney preservation and no complaints of pain or such. So we decided to stay expectative. In that regard, we did give her bladder installations to calm down the urothelium, and we have checked her. And I just saw her recently. Actually, the hydronephrosis stayed for a while, but in her last check, she had no hydronephrosis. So that was interesting, and I scheduled a new renography because I'm keen to see if it actually is now not symmetrical, but there's no obstruction anymore. In the follow-up, personally, I'm very interested because we know that in chronic bladder irritation that could lead to malignancies, but we're not really sure whether that should be included or it should be a reason to do a TUR anyway. There's one good systemic review from 2021 and no real data after anymore, which combines 76 studies with 184 patients. The main group of 140 is local disease, AL amyloidosis. And since then, there's a few case reported and one case series reported. So there's not much literature, and the total amount of described patients is very heterogenic and it's not a lot. The symptoms are hematuria, storage or voiding LUTs, mimicking cystitis, can be an incidental finding on CT or MRI. And as with our patient, it's cystoscopy. It looked like bladder cancer, maybe stone formation, irregular bladder wall, and typical these yellowish spots. This was another case, right?
Yeah.
Within a very extensive bladder amyloidosis, also clearly showing all these yellowish see-through. And this is a fairly calm bladder, so this is not really inflamed as much, but it also becomes very rigid tissue. So the treatment, yeah, I think we can debate about the treatment for sure. TUR bladder, we also have to ask ourselves, what is the goal of the TUR? Do we want a diagnosis? Do we want a radical resection, which is probably not doable since it extends through the whole bladder wall? Or is it a treatment, and what are we treating? We came upon colchicine in the review, but here in our department, we were told that that is not common standard anymore. DMSO, so we also gave bladder installations to calm the urothelium, but it doesn't seem to treat the disease or maybe solute the proteins. And of course, if the whole bladder is affected and it's not functional anymore, or there's bilateral hydronephrosis, yeah, we should consider bigger reconstructions like reimplantations or cystectomy or partial cystectomies. In the follow-up, there's a risk of recurrence, of course, depending on what kind of therapy you give, and the recurrence is usually within 2 years. We asked ourselves, is there a risk of bladder cancer? There is one pathology study who has investigated 29 cases, and they reported a 48% of concomitant or later bladder cancer in this series. So it seems wise to do a cystoscopy after 3 months, 1 year, 2 years, and maybe even after, or do it when people have complaints again, like hematuria.
So this is a flow chart that was suggested from this large systematic review. All the steps, everything as we did it, as well as you would do as a urologist. But there is no mention of the chemotherapy as we saw in our patient with urethral disease, or radiotherapy as we saw in our patient with bladder disease, for primary amyloidosis. And that was new to us. So that's why we need an expert to share her opinion. So I'd like to invite Professor Minnema to give her perspective.
Thank you. Yeah, so as stated before, I'm a hematologist, and I would like to explain something about amyloid and amyloidosis, and also about how these amyloid deposits can origin in several parts of our body. Foremost is that we have different terms for this. So amyloid it's what we mean is the deposited material itself. Amyloidosis is the disease caused by these amyloid deposits. And what's very typical of these amyloid deposits that they are extracellular and that they are in a fibril formation. So, for example, for the kidney, you can do electron microscopy, and there they can actually see the fibril formation of these amyloid fibrils. It's not only a protein, the amyloid precursor protein that forms the fibrils. There's also other proteoglycans and also serum amyloid P present in these fibrils. So it's a complex of several proteins. And those the proteoglycans are, for example, proteins that are on the outer layer part of our cells. And serum amyloid P is just a component of our bloodstream. It's a protein in our bloodstream. So the word amyloid was already introduced a long time ago in 1854 by Rudolf Virchow. And he believed it was some kind of starch or cellulose, but later on we found out that it was a complex protein in a fibril deposit formation. If we go to the next slide. It was already mentioned by Sanne, but the gold standard to see amyloid fibrils is a Conco red staining, and that's not a standard staining for our pathologists. Sometimes you can see amyloid deposits with normal dyes, but if you want to prove it, you need to have concurrent staining. And then they have to do something with a microscope. They call it biofringence. And there you can see on the right side, you can see what happens to those concurrent stains. You can see some lightening of green or yellow, sometimes orange, and that makes the proof of amyloid fibrils. And that's because the concurrent dye is taken between the fibrils and gives this very typical presentation. And if you move forward, so this means that you can't diagnose this on cytology. So you need a biopsy, histology, and it helps the pathologist a lot if you think about amyloidosis to ask for this concurrent staining, because if you don't ask for it, they can miss it. And if you go one more, that's also what was also mentioned by Sanne, is that not every pathologist can do this. Everybody can do the concurrent staining, but we notice also in our institution that not every microscope is able to see this biofringence as well as other microscopes. So if you think about this disease, but your pathologist can't find it, please ask for a pathology referral to one of the expert centers, because that's what we need to demonstrate it. Now, then something about amyloid and amyloidosis in a bigger picture. So we categorize amyloid and amyloidosis with the term of the precursor protein. And with the precursor protein, we mean the protein that is leading to the amyloid fibrils. And we are talking about AL amyloidosis, but we have more than 38 precursor proteins already identified in our body that can form amyloid fibrils. So there's much more than only AL amyloidosis. And there is if you can go one back. Sorry, there's a society, the ISA, the International Society of Amyloidosis, and they update this nomenclature every 2 years. This is from 24, and there we can see all the new or perhaps extensions of this precursor proteins. But we are talking about AL amyloidosis, and AL stands for amyloid immunoglobulin light chain amyloidosis, and that's the most frequent amyloidosis there is. If you go one more, you have it both in the systemic form. But we are talking about a localized form. So normally when you go to a hematologist, you have the systemic form, but the localized form is also possible with AL amyloidosis. And in the systemic form, it's a very extensive disease. In the localized form, it's a very localized disease. That makes sense, of course. And below this, you see some of the other forms. AL is associated with rheumatology, for example. Some rheumatology syndromes can form AL amyloidosis, and nowadays ATTR is really rising because that's a form of cardiac amyloidosis that happens in elderly people. So ATTR amyloidosis now is the second frequent type of amyloidosis, but that's mostly not in the bladder, but it's mostly in the heart and the nervous system. If you go on, so what are immunoglobulin light chains? That's something that we work with all the time, but these are the immunoglobulins that are secreted by our normal plasma cells. And a immunoglobulin has a heavy chain, so that's the blue part, but it also has a light chain. And in the normal situations already, we have a slight overproduction of light chains. So you have free light chains already circulating in your bloodstream. And when we talk about the normal situation, you see that on the right. So you have normal plasma cells, and they have a wide variety of immunoglobulins, or also called antibodies, to tackle all our bacteria and viral infections and after vaccination, of course. But then on the left side, you see what happens when you have clonal plasma cells. And the most known disease for clonal plasma cell proliferation is multiple myeloma. And there is one cell expanding a lot, and then you only have one type of this antibody being produced, and that type is called a paraprotein or a monoclonal protein, but it can also be an excess of one of the light chains. And the light chains, we have them in a lambda form and the kappa form, and they are in a normal distribution in our bloodstream. But if you detect only plasma cells with only, for example, a lambda light chain expression, then you know you have clonal plasma cells. And then we come in. And I also mostly like to see, if you click one more to this guy from Twitter. It's Dr. Klaukenflekke, and he makes funny movies about everyone. And we hematologists, we love our cells. So this is the plasma cell. So I am a plasma cell nerd in hematology. So amyloidosis is a hematological disease, but for example, ATTR amyloidosis is not a hematological disease. It's caused by clonal plasma cells or B lymphocytes, and they are producing these amyloid-forming light chains. We have two forms, the systemic form and the localized form. And in the systemic form, you have those clonal plasma cells or B cells in your bone marrow. And the bone marrow is a big organ. So this is the pelvis, but it can also be in your spine, in all your vertebrae or in your skull. So those clonal plasma cells produce immunoglobulins and light chains. They are misfolding already inside the bloodstream, but really forming the amyloid fibrils when they attach to the outer layer of your, for example, kidney cells or cardiac cells, your myocytes. And systemic AL amyloidosis, if you can go one more, is a systemic disease. So here's a picture of all of the complaints a patient can have. Mostly involved are the heart. So it's heart failure with edema, dyspnea at exercising. Fatigue is a big problem, but it can also be in your bloodstream. It's in your bloodstream, but also in your vessels. And very typical and pathognomic of systemic AL amyloidosis is the enlarged tongue, so a very big tongue, or the purpura under your eyes. It's called raccoon eyes. But you see, if you go one more further, that except the renal system, there's a big empty place there where your bladder is. So your bladder is not a part of systemic AL amyloidosis in most cases, but when it's in your bladder or urethra, it's mostly part of local AL amyloidosis. So localized AL amyloidosis has one organ involved. Very typical is the mucosal localization. So in a mucosal organ, amyloid is not happening by accident. It's there because there is mostly a B cell clone or a plasma cell clone present somewhere in your mucosa. And perhaps it's there because of some kind of infection. We actually don't know, but the cause of this protein, of the amyloid deposit, is always a cell, a B cell clone or a plasma cell clone. And very typical in localized AL amyloidosis that we see much more B cell clones than plasma cell clones than we see in systemic AL amyloidosis. Of course, it's a very rare disease. Treatment is difficult, but I will try to tell something about it. There are no trials, so it's a lot of common sense. And importantly, patients with localized AL amyloidosis have a normal survival. And that's a big contrast with systemic AL amyloidosis because that's a very lethal disease. And if you move forward, this is from a paper from Dr. Mahmood from the National Amyloid Center in the UK, which is a very large and experienced center, and they have a very large database. And in 2015, they published in the Hematology Journal a very big cohort of patients with localized amyloidosis. And I will tell you something about this paper. The most frequent localization of localized AL amyloidosis is, in fact, your bladder or your urethra. 16% of the patients had a localization there. The other very frequent localization is your larynx or pharynx, where amyloid deposits can happen. Your skin was seen in 14% of the patients, and pulmonary nodules or endotracheal localization of amyloidosis was seen in 8% of the patients. So this is a slide, also a graph also from this same paper. So they identified 600 patients with localized AL amyloidosis, and of 501, they could type the amyloid. And you can see 490 actually had AL the light chain amyloidosis, what we are also talking about, but some patients had another form of amyloidosis. So it's not 100% AL amyloidosis when it's localized. And then you can see, if you move one more further, is that 7 of these 606 patients progress to systemic light chain amyloidosis. So that can happen, but most of the patients' state remained as a local light chain amyloidosis. And of 527, they had treatment details. And of those, half of those did not need any intervention at all. So that's, for example, you can have amyloid on your skin, and that's not a problem at all. But half of the patients needed intervention for symptom relief. So important to know that not every localized AL amyloidosis is treated. So if you think about treatment, you have the mucosal membrane, you have the amyloid there, and you have some clonal cells there, some cancer cells there. They are very difficult to see in biopsy. So we were lucky in these 2 cases that we could see them, but in many cases, the pathologist cannot find these clonal cells because they're so sparse or they're somewhere else in the organ. So if they're not seen, it's more difficult to decide what kind of systemic treatment we want to give, if we want to give it. So as seen before, 50% of patients are in need of local symptom relief, and I think it's mostly debulking of the amyloid. So the amyloid is just a fixed deposit, and if it's giving problems, you have to debulk it, and you can do it with surgery, but for example, the larynx, pharynx, they do it with laser surgery. And I think you can remove some of the clonal cells, but mostly it's more spread throughout the organ, so throughout the mucosa. So I think if you only debulk, you have a higher chance perhaps of recurrence. And that you can see, this is the same slide again. So you can see on the top, 50% did not need intervention, 50% did need an intervention. And of those intervention patients, also around 50% needed more than one. So it's not done with one intervention, one debulking, you needed more. So, and of the more interventions, most of them had received a local repeat intervention. And if you move one slide, I think that this repeat intervention can also be because if you only debulk, you can have some clonal cells still present in the organ. And if you treat the cause of the amyloid deposits, the cells, the B cells or the plasma cells, you can perhaps achieve a less frequent repeat intervention or less frequent recurrence of the disease. So how can we kill cancer cells? We can do it with local radiotherapy. And indeed, the dosage for hematological malignancies is much lower than for solid oncology. So that's the intervention that was given to the other patient is enough to treat that disease. But if you can't give local radiotherapy, you can also think about systemic chemotherapy. Systemic therapy. And we used to give a lot of chemotherapy, but I highlighted that especially in hematology, we moved away from classic chemotherapy. What we are giving now is targeted therapy and immune therapy. That's our most important tool that we have. And I do believe if you give 2 more clicks, I think that if you look at this review with so many patients, in the end, only 4 received systemic chemotherapy and 18 local radiotherapy. And this is a paper from 2015. And I think with the new thinking about the pathophysiology of localized AL amyloidosis, perhaps we are underutilizing these treat the cause modalities that we have nowadays. So this is also, this is my last slide, also from the same review. If you give one more click, because then I put away the laryngeal and pulmonary. And in this cohort, they were 95 patients with bladder localized AL amyloidosis, urethral 10 and ureteric also 10. You see some of the symptoms they had, but you also see the symptom duration. So that's also very typical, of course, for rare diseases. It takes a while before the diagnosis is made. And with urethral, it was a median of 1 year. In none of these cases, the associated underlying clonal disorder was found. But some of the patients did have a paraprotein or M protein or increased free light chains in their bloodstream. So they are produced by the clone that is somewhere in the organ. This is the abnormal kappa-Lapa ratio, what I explained before. You can also see the type of surgery they had, laser and surgical debulking. And a lot of patients had progression at the primary site. And I also found a paper on DSMO. I think it was based upon one case report a long time ago. But in fact, we don't have amyloids, amyloids, how do you say that? Amyloids, anti-amyloid therapies. We don't have effective therapies that can break down the amyloid. And I think DMSO was used for a lot of things in the days, but I really can't understand the rationale for that at the moment. I think that is my last slide. Yes.
Yeah, so bringing this all together, if you look at how does it cause bladder symptoms, it's the stacking of the amyloid. Obviously, the cells are so little, but they're the cause of the amyloid deposits, and it's the stacking that causes the symptoms, can lead to reduction of bladder compliance, so the extendability of the bladder with low pressure, which can cause an increased sensation of bladder filling and a decreased bladder capacity, leading to the OAB symptoms as we had in our patients. But it can also undermine the urothelium. We did a nice TOR recently where you can really see that the deposits are between the muscle and the urothelium. And if it goes to a certain extent, it can put so much strain on the urothelium that it breaks or becomes deficient as a barrier, leading to protrusion of solutes of the urine, leading to inflammation, uroinflammation. And in that way, it could also be a progenitor of malignancy as the barrier is broken and broken in a chronic way because the disease is only discovered so late. Similarly, in the urethra, it's also the stacking disease, and then it would be very similar to spongiofibrosis as a mechanism of urethral stricture. So by undermining the mucosa or by stacking in the spongiosum, the blood supply and the oxygen to the mucosa would be more and more limited, leading to stricture formation. And in that way, in a certain extent, it could mimic conditions like lichen, hypospadias, and radiotherapy, where the spongiosum is completely deficient, which would lead to a two-stage procedure more often than a one-stage procedure if you want to reconstruct. Again, this is all management of the stacking, as we said, and does not solve the problem of the clonal cells. And in my view, or in our view, this is probably the reason why the recurrence levels are so high, because you don't take away the cause, you take away the consequence and the symptoms, but it would just start stack again. So the take-home messages are that lower urinary tract is a very preferred location for local amyloidosis, mostly of the AL type. We saw that for an adequate diagnosis, you need tissue, you need a specific coloring and microscope, and looking at the cells and typing of the cells to get the full picture if possible. Now, for the symptoms of the lower urinary tract, you can apply local and standard urological treatment as we do for these causes. But due to the high recurrence and the consideration of the monotypical plasma cells, that would not be enough to avoid recurrence. And I think adjuvant treatment is currently underutilized and needs definite consideration in patients where amyloidosis is found in the urinary tract. So in that regard, as we have experienced, it is very worthwhile to cooperate with the hematologist to design the best treatment plan for individual patients. And we'll see, hopefully, the recurrence gets less than reported in literature by this combined approach. And I think we should both be involved. We have been involved in patients that were referred to the hematologist for urological amyloidosis, and vice versa. We have referred to the hematologist. I think the two-way learning and interaction and cooperation is very worthwhile for, in both regards, a rare disease. So that was the presentation, and now there's always room for questions in the chat, I think.
Yes, thank you so much. I did see one question come in during the talk, so you can find it in the Q&A section, or maybe for you it's the VNA. Depends on the language your Zoom has selected.
VNA, yes.
Because amyloidosis of the bladder has a risk of hydronephrosis and kidney dysfunction, how would you suggest follow-up of kidney function long-term? Should it be done with lab, ultrasound, or cystoscopy, or combination? Yes, we're not sure. I did not do anything when she was referred because it was already existent for a longer time. She had no complaints. So I thought if I put a double J catheter in, I can also give her more complaints. And if I do surgery, I'm not really sure if I can completely resect that part of the bladder because it was also very low, very close to the bladder neck. We said we're going to hold the disease, hopefully with radiotherapy. We're going to calm down your bladder a little bit with the bladder installations, and we're going to see what it does because we had no literature reference. And now just keeping hands on the back, we see after 15 months that her kidney is not dilated anymore. So I think that can be done. The only thing that I'm a bit worried about is that she can get a secondary tumor because of the chronic inflammation of that segment of the bladder. So I will do a cystoscopy, I think 2 years after radiotherapy, and see if we can have a good comparison. But it will be hard because it's also a hard, it's not like one papillary lesion. It's quite an extensive place. We also did an extensive TUR of another bladder, and I think what we can take from that is in what amount we can see re-epitheliation above the tissue, because if the barrier closes up again, that would be a good reason to do a TUR, but right now I'm not so sure.
Yeah, we'll have to see. And I think the main thing with the hydronephrosis is to actually stop the disease progression. So treat the cause, and the stacking itself, it won't progress. So you should not expect it to increase the narrowing of the ureter after you've treated or attempted to treat it clonal cells. So I think it again underlines, well, of course, essential follow-up, but also the systemic treatment. Next question is by the same person, I think. When radiotherapy is used for bladder amyloidosis, how many times would be worthwhile to repeat radiation before there is unacceptable risk of unintended consequences? I think that's a difficult question. We're not radiotherapists, so I think it's a balance between a dose in which you expect to actually have treated the clonal cells versus overdosing. So in our cases, that the dose was relatively low, 12 repetitions with 2 gray, and that's what came back every time when we requested the radiotherapist. So yes, I think it's a matter of balance, but in all, it's quite low compared to other urological diseases in where you treat, which you treat with radiotherapy. I don't know if Professor Minnema has something to add.
Yes, I think that's indeed we are with 2 specialists, but indeed radiotherapist is, I think, in our case always in goal. They say when it can't be done anymore. My suggestion is if radiotherapy fails, perhaps in a very specialized situation you can use it again, but why should you use it again? If it fails so early on, perhaps then it's also time to move on to other approaches like systemic therapy. But I think when you have a more diffuse disease, then of course radiotherapy is less attractive. But when it's still very localized and can be used on different parts of the bladder, perhaps the radiotherapist has more options then.
All right. I hope that satisfies the question. Next one is on the installations of heparin and lidocaine or lignocaine in recurrent symptoms of hematuria, how this would help. So how it works is that you try to reinstate the gag layer of the bladder, and the gag layer has different components. Most known are hyaluronic acid and chondroitin sulfate, because those are available in commercial products. But heparin is another constituent of this gag layer. It's something that, well, these installations have been reported, probably also a bit underreported because there's no commercial interest, if I'm allowed to say that. But they're readily available and have shown good results as well. And in the Netherlands, it's a matter of reimbursement, in which there is no reimbursement for the installations. So yeah, we had to be creative and came to this solution, which so far has given us good results while awaiting a large study that is running to reacquire reimbursements for the other products, because you do need to mix up some things, whereas obviously it's more easy for patients if it's in one syringe and capsule ready to use. So it's hopefully a temporary solution, but it's based on the same principle as other bladder installations. So you want to reinstate the gag layer, restore the bladder barrier, and thereby reduce inflammation and hence lead to less hematuria.
Great, thank you. I will wait a couple of more minutes if people have any questions so they can type that in. And in the meantime, I would like to mention that the webinar has been recorded. So we will send out the link for the recording tomorrow via email. And we will also put it on our YouTube channel. So make sure that you follow our YouTube channel if you would like to see all our other past webinars. Like Michel mentioned at the beginning, the webinar is accredited. So if you fill in the survey that you will get immediately after the session has finished, that will not only help us continuously improve our webinars, but also you will get the certificate in 2 weeks' time. No more questions that I can see so far. So I would like to thank you, the presenters, for the very interesting presentations. Thank you so much. And thank you to the attendees who have joined this webinar this evening, and have a nice evening. Goodbye.
Thank you.
Thank you.
Bye.